Welcome, everyone. Thank you for joining us today. We're so glad to have you with us for this special webinar hosted by the Heart Center at Boston Children's Hospital. And today we're going to be discussing minimally invasive atrial septal defect repairs. Today, we'll explain how our multidisciplinary team uses cutting-edge techniques to repair ASDs with smaller incisions and a multimodal approach to pain control, and with the goal of shorter hospital stays and quicker returns to daily life. We know how overwhelming it can be when you find out that your child needs surgery, but our goal is to walk you through it so you feel informed about treatment options for your child. Today, you're going to hear directly from the members of our dedicated team of providers as they share insights about what an ASD or an atrial septal defect is, when it needs to be repaired, our innovative surgical approach to the repair, our enhanced recovery program, and how we're going to support the patients and families through this journeys. And we'll also have a Q&A at the end. So let's get started with introductions. My name is Samantha Parsons. I am a cardiac surgery physician assistant. I'm going to be facilitating the discussion today, and I'm also a member of this minimally invasive ASD team. My role in the program is to serve as a point of contact for the families, speak with them beforehand, be part of the procedure itself, and then also follow up after, making sure that there's a continuity of care throughout the experience. Next, we'll move on. And Dr. Baird, could you please introduce yourself?
Dr. Christopher Baird, one of the heart surgeons here at Children's of Boston, one of 8 or 9 heart surgeons. All heart surgeons perform atrial septal defects repairs. However, a few of us have a special interest in minimally invasive approaches to atrial septal defects.
Wonderful. Dr. Farias, would you mind going next?
Hi, everyone. I'm Dr. Michael Farias. I'm a cardiologist and interventional cardiologist here at Boston Children's. So I am one of the cath doctors that also can close atrial septal defects in the cath lab when they're appropriate. We'll talk a little bit more about that in a bit.
Thank you. Dr. Ma?
Hi, my name's Candace. I'm one of the cardiologists at Boston Children's, and I'm also work in the imaging department. So my job is to oversee when the patients come through and also to diagnose them using echo or other modalities.
Thank you. Dr. Roy?
Hi, my name is Dr. Natalie Roy. I'm one of the cardiac surgeons, but also I'm a critical care physician. And in this, I also am the director of the Enhanced Recovery After Cardiac Surgery program, which is a comprehensive approach that includes the entire perioperative care of the patients from diagnosis all the way to recovery. And we'll be speaking about that a little bit later.
Thank you. And Dr. Atkinson?
Yes. Hello, everybody. My name is Doug Atkinson. I am a cardiac anesthesiologist and cardiac intensivist here at Boston Children's. So I split my time between anesthesia in the operating room and cath lab and in the ICU during postoperative recovery.
Wonderful. Thank you. And Victoria, would you mind introducing yourself as well?
Hi there, my name is Victoria Perchinock. I'm one of the case coordinators in cardiac surgery. I'm going to be working alongside this team, and my role is to meet with families from the very beginning, from the second opinion outreach, as well as meeting them in person for when they do come for care.
Great. Thank you, everyone, for being here today. So let's get started. Doctors Ma and Farias, could you guys start by explaining what an atrial septal defect is, when we refer patients for repair, and why some can be done in the cath lab and why others might need surgery?
Thanks, Samantha. I'm going to start with just some anatomy. So can you see my screen?
Yes.
Yeah, perfect. So starting with what the heart looks like, we have 2 sides. We have the right side and the left side. The right side collects low oxygen blood and then pumps it off to the lungs so it can collect oxygen, and then it comes back onto the left side where it then pumps off into the body to supply oxygen for the rest of the body. In order for the 2 sides to stay separated, there has to be a septum or a wall between the top chamber and another thicker wall between the bottom chamber. An atrial septal defect is when there's a hole in the top chamber wall. All of us are born with a little hole that then tends to go away, but in the cases of atrial septal defects that require intervention, that hole can be much larger. And so one of the indications for us to go ahead for surgery is if that hole is large and is causing the right side to dilate significantly. We tend to see these defects occur in about 1.5 out of 1,000 live births. And we also tend to diagnose them and the reason we have to intervene on them is because over time they can cause pulmonary overcirculation or a lot of extra blood into the lungs. And if left for a very long time, they can cause pulmonary hypertension. They are diagnosed simply by listening, and your pediatrician or your family doctor can often hear a heart murmur that then often is confirmed on an echocardiogram that shows an ASD. And they're treated by what we're going to discuss today, which is either transcatheter closure or surgical intervention. And a quick look to see what that would look like on an echo is that you have the right-sided top chamber here and the left-sided top chamber here, which we call atria. And you tend to have this flow or this hole that's coming between the two sides. So normally it would be separated by that septum or that wall between them.
Thanks, Candace. I can take over and talk a little bit about cath-based closure. So for those who aren't aware, cardiac catheterization is where we put catheters into the vessels in the body and then thread those catheters up to the heart where we can take pictures, take pressure measurements, and then do interventions. And specifically now to talk about transcatheter ASD closures, Candace really showed you nicely how the atrial septal defect is a hole between the top two chambers of the heart. I'll show some pictures of devices that we can put in either through the vessels in your leg or other vessels in your body, thread those up to the heart, and then put this, which is kind of a double disc device with one disc on one side of the hole, and then put the other disc on the other side of the hole to sandwich the hole together and close it. There are several different devices that we can use. The most commonly used in the past has been the Amplatzer ASD occluder device, which is made of a nickel titanium alloy called nitinol. Has a very low risk of complications, but has been reported to erode through the heart because of that metal being in the moving heart. So because of that risk of erosion, a lot of people have kind of gone to the newer generation devices, which are over here on the right of the screen. These are also nitinol, but the nitinol is in the frame of these Gore-Tex devices, which have that Gore-Tex material in between the frame. And then similar to the Amplatzer device, you can put one disc on one side of the hole and another disc on the other side of the hole. So this is an example of an atrial septal defect that I closed in the cath lab, where you can see here the device is attached to this catheter, which is actually coming out the patient's leg. And then once we're happy with this, with the device both by X-rays, which you're seeing here, and then echocardiogram, this is a transesophageal echocardiogram probe, we can release it and the device takes a very kind of pretty flower-like petal arrangement and closes the hole. But as Samantha kind of alluded to earlier, not every hole is amenable to cath-based closure. This is another view of the atrial septum in an anatomic approach to show that the atrial septum is between the two chambers, but it's also close to a lot of normal structures in the heart. So this SVC and the IVC are the superior and inferior vena cava. Those are the big veins that drain blood back to the heart. This AAO here is the ascending aorta, which carries blood from the heart to the body. And then this TV here is the tricuspid valve, which is an important valve in the heart. So you can see here the atrial septal defect being in the middle can be close to those normal structures. So when the ASD is very, very large, it can be unsafe to place a device into it. Also, if some of these tissues that surround the ASD between the normal heart structures aren't sufficiently long enough, then we don't have anything that the device can grab onto. It's what's called an insufficient rim, and then we can't safely place a device. And then last, if the device, let's say we can place a device in, but it's just too close to the conduction system of the heart, which is down here, or the valves of the heart that we're worried it will interfere with the conduction system or valve function, then it's not safe to place a device. And then those are reasons why if we can't minimally invasively close it in the cath lab, we would refer to Dr. Baird and our surgical colleagues for surgical closure.
Perfect segue. Dr. Baird, could you please talk now about the surgical options for repair?
Sure. Can you see the image? Is that image being shared with you guys?
Yes, we can see it.
So typically, when we have done heart surgery for atrial septal defects or any heart surgery for that matter, we've done a full sternotomy. And as you can see here, that would be the upper sternotomy and mini-sternotomy combined. And that gives us generally very good exposure to any of the heart structures. And over time, that evolved where we did a mini-sternotomy. And then we've even gotten somewhat smaller on the mini-sternotomies in order to approach the atrial septal defects. However, that still requires splitting the sternum and potential for sternal instability later. So therefore, we've evolved, and I'm going to bring up another image. Now, can you guys see the new picture?
Yes.
Yes.
So now, as you can see here, this is an incision up under the armpit on the side. And in fact, we can frequently make it smaller than this picture illustrates, and somewhere in this dimension. And what that does is it gives us direct access to the area that we need to close the heart. But most importantly, what we can do when we do that is we can use our standard cardiopulmonary bypass techniques. And to me, that's a really critical part, because if we can do things in a standard way from the way we manage cardiopulmonary bypass, that limits the potential complications from trying to do other forms of cardiopulmonary bypass that's required for other potential procedures to close ASDs, for example, as compared to a robotic ASD closure, because then you have to use different cannulation techniques. So it's a tremendous advantage to use standard cardiopulmonary bypass in this so-called armpit or axillary thoracotomy incision that's really hidden over time. And another tremendous advantage is we don't have to split the sternal bone or split any bones for that matter, particularly in younger children. We just spread the ribs and go through the ribs, and then we pull the ribs back together when we're done. And generally, these patients heal very, very, very quickly. I'm going to let my colleagues in just a minute discuss the pain management, but we've come up with a strategy for these patients to have pain managed in a different way than we do for sternal incisions, which appears to manage this pain a lot better. And in fact, most of these patients now have pain well controlled and can leave the hospital by postoperative day 2 or 3. So with that, I think I'll turn it over to Dr. Atkinson to talk a little bit about how anesthesia is managed for these patients and some of the differences in their approach for anesthesia when we're doing these minimally invasive axillary thoracotomies.
Yeah, thank you, Dr. Baird. I would say in a lot of ways, the anesthetic management is very similar in that we provide general anesthesia regardless which approach the surgeons use, sternotomy versus thoracotomy. So that means that an anesthesia team will fully anesthetize the child, have them be asleep, unaware of the circumstances in the operating room. Usually that involves giving some medication in the holding area, so the child gets amnestic and sedated right from the start, right when they're in their parents' vicinity. And then we go back to the operating room where we can have them breathe off anesthesia vapor and go fully to sleep before really even doing IVs sometimes. After they're asleep, the big differences between the approaches the surgeon takes with the thoracotomy comes down to how we can manage pain and analgesia during the operation as well as after the operation. So with the newer minimally invasive thoracotomy or side incisions, we are using a regional anesthetic technique, which means we use an ultrasound machine to identify where the nerves that go to the surgical site live. And then we can inject local anesthetic medicines, numbing medicines, to surround those nerves and make those nerves numb and really reduce pain transmission from the surgical site to the pain pathways to the spine and brain. So regional anesthesia is a central component to the analgesia or pain control during and after the surgery. We really, we may say this a couple of times, we use a multimodal approach to address post-surgical pain. That means we use several different medications that act in different ways. We use local anesthetics directly into the wound. And then the central component, we use a regional anesthetic technique where we're depositing local anesthetic directly onto those nerves. For the thoracotomy, our current preferred regional anesthetic technique is called a paravertebral nerve block. In children especially, we can use ultrasound to really see all the structures pretty well. And we identify the nerves as they exit the spine. So not on the spine like an epidural, but adjacent where the nerves are leaving the spine. And we can inject local anesthetic right on into that area where the nerves are exiting to reduce the pain that they have intraoperatively and postoperatively. And like Dr. Baird says, we've had a high success rate, and there's really extremely low complications using the ultrasound-guided regional anesthetic techniques. I should say we use a full array of different regional anesthetic techniques. There are sometimes where the paravertebral nerve block isn't the best block for the child for various reasons, and we have all the different techniques available to us in cardiac anesthesia.
Thanks, Dr. Atkinson. And so since we're on the topic of pain management and recovery, now feels like a nice time to hear from Dr. Roy about the Enhanced Recovery After Surgery program at Boston Children's. Dr. Roy?
Thank you. I'm going to share my slides. There we go. Let me just go. So the Enhanced Recovery After Cardiac Surgery, or ERAS cardiac program, is really a multidisciplinary approach that we have pioneered here with our colleagues from cardiology and anesthesia, as well as the surgeons and our perfusionists in the operating room, to really try to get to a place where we're optimizing every part of the surgical journey. And that starts with, before the surgery with education. And at the time of the surgery, Dr. Atkinson talked about the multimodal pain regimen that we use in the operating room, but also that's continued after surgery. That allows us to take the breathing tube out often in the operating room for these minimally invasive ASDs, and now a majority of our simple same-day cases where patients come in for surgery. And then in the postoperative period, we have some protocols to try to remove the lines and the IVs that are painful for the children as early as it's safe, so that they can move around and recover faster. We do, as Dr. Baird said, use innovative surgical repairs and use increase in regional blocks, which we've studied reduce opioids at the time of surgery. And then we have, all these postoperative components of care that are brought together really to try to get patients to recover faster, and they get to go home faster because they've reached their milestones for going home faster. In the postoperative period, we use an application to follow the children after surgery with some voluntary questionnaires, and there's also a way for families to send pictures of the incision if they have concerns, and we have additional in-person and virtual visits to tie into all that.
Thanks, Dr. Roy. Now, I'd just like to talk a little bit about the actual course of the hospitalization, what the experience is like for the family. So once you have had your surgery scheduled, you'll come to the hospital in the morning of. Typically, the surgery will take part of the day, and by the afternoon, you'll be in the intensive care unit with your child. Most people spend one night in the intensive care unit, and then, as Dr. Roy said, as soon as it's safe, we take out the breathing tube, the IVs, the lines, etc. And most patients will transfer to the step-down unit or just the ward on the first day of surgery. And then typically most people are spending 1 or 2 nights in the hospital and go home 2 or 3 days after their surgery. And now, working backwards almost, Victoria, would you mind explaining how families can go about getting in touch with us if they think that the minimally invasive ASD repair might be the right choice for their child?
Of course, thank you. So we have a couple of different ways as to how families have reached out to us in the past. We do have an app available through the App Store. It's called Heart Opinion. So families can download that, create an account, and submit their inquiry. We also have a link on our website through the Department of Cardiac Surgery. A lot of families actually have coordinators, our DL, our team's DL. So we all do the same thing, and we're all split up by different programs, languages, surgeons. So they'll reach out to us directly, or they'll reach out to us to our team, and our contact information will be at the very end. So what will happen is once I receive your inquiry, we'll go through, we'll have a phone conversation. We'll collect the data, so that will be any recent cardiology reports, clinic notes, echo, MRI, CT, CAS reports, and images as applicable. We'll get it over to this clinical team to review, and then we will move forward with recommendation letters. We could do a visit, consult visit with these providers to answer any last minute questions. And then if you're ready to come for surgery, the cardiologist will submit the scheduling paperwork, and scheduling team will reach out to schedule dates for you. And then once you actually arrive, I will be meeting with you in person, provide you with a tour of the hospital prior to the appointment, as well as keeping in touch with you while you're here and checking in with you and giving you discharge paperwork.
Maybe I can also add to that if that's okay. Victoria and her team do a fantastic job coordinating, but she mentioned something that's really important, which is we fully thoroughly review your case. So that includes reviewing the images to see if you may be a candidate for the cath lab. So we would be able to provide an opinion for that as well. Provide you all the options that would be available for your child, and then help you make the decision that's best for you, your child, and your family. So when you ask us for an opinion, it doesn't mean that we're going to recommend surgery necessarily. We'll give it the full medical review.
Thanks, Dr. Farias. Dr. Baird, do you have anything to add?
No, I think what's important to, at least an important takeaway, is this is a team, an entire process. I can be an expert or specialize in doing an axillary thoracotomy and doing this procedure, perfect. But all the other pieces here, and you've heard from many of these folks that really help make this process happen. That's really what makes Boston Children's, I think, stand out as exceptional, in the sense that you have experts in every one of these aspects of the care. So by me being able to rely on each of the other providers, I can focus on exactly what I need to do, and therefore we can all benefit from that, and your child actually receiving the best care possible. So I truly believe that. And as you see, there's a lot of interdisciplinary or cross-disciplinary care. Dr. Atkinson not only works in anesthesia, he's director of our kind of acute care part of cardiac surgery for patients that undergo surgery and then go to the PACU rather than the ICU. He attends in the ICU. Dr. Roy, as a cardiac surgeon, is also director of the critical care portion for the surgical part of the ICU. Dr. Farias sees patients in the outpatient, yet he's in the catheterization lab for performing procedures. Dr. Ma not only sees a lot of patients outpatients, but is one of our echocardiographer 3D experts. So we have a lot of experts in their own field contributing to what I think is a really nice program here. So I think that's a huge benefit of the program, not just the fact that you're going to get a small incision that's minimally invasive to fix the defect, but it's a real package that can give the best quality care for your child.
Thank you, Dr. Baird. Does anyone have anything else they wanted to add before we get to the Q&A portion of today's session? Okay, great. So far I only see one question, and I believe this would be best for Dr. Atkinson. The question is, can you explain what anesthesia is used for the cardiac cath ASD closures? How is that different from our thoracotomy surgical repairs?
Yes, I can answer that question. Thank you for asking. The management for anesthesia for the cath lab approach is similar in that it's a general anesthesia. Typically speaking, we would provide some medicine in the holding area while the child's with the family to have them calm down and be quite sedated. And then again, we go to the cath lab where the anesthesia team gets them monitored and then has them go off to sleep, usually with breathing inhaled anesthesia, followed by some IV placement and IV medicines to keep them asleep and comfortable. We typically would use a breathing tube for the duration of the cath procedure. So the anesthesia team places a breathing tube to allow them to help breathe for them with the machine, as well as to provide some of that anesthesia gas that keeps them nice and comfortable. Because the cath doctors, and Dr. Frias may comment further, or Dr. Ma, often would like to see an echo images from a transesophageal probe. That means a small little camera on a long tube is placed down the patient's esophagus or the child's esophagus. It's best to have them asleep with the breathing tube and be still for those images to provide the most information. But at the end of the procedure, when they're all done, we reduce the anesthesia vapor, reverse any medicine that we need to, and have them wake up and be ready to go. In this case, they go to the PACU, or the post-anesthesia care unit, where they're monitored for several hours before being admitted to the hospital floor. So they are extubated. The breathing tube comes out at the end of that, and they don't require the regional anesthesia because they don't have the surgical incision and dissection. They're often given local anesthesia medicine to the sites where the cath doctors will get access to the vessels for the devices. I hope that answers the question, but happy to address it further.
I can add a little as well. As Dr. Atkinson mentioned, after the cath is done, usually pain is controlled with just Tylenol and ibuprofen because it's requires a much smaller incision, really just a Band-Aid site on the leg. And that is in general why when ASDs are amenable to cath-based closures, we've typically recommended the transcatheter approach. But I actually have had two patients that I've sent to Dr. Baird for the minimally invasive thoracotomy approach when they're not amenable to device closure. And even as recently as 5 years ago, I would kind of have the argument to make that the catheterization and the recovery, which is, a bit faster recovery and less painful, is better than the sternotomy. But now with this thoracotomy approach, is really a significantly improved recovery from cardiac surgery. And both of those patients have done tremendously well, leaving the hospital within a few days. So it's kind of getting closer to a faster recovery for the patients to compare that minimally invasive approach versus catheterization.
Maybe I can just add a little bit on the pain difference. In the patients who get surgical approaches, obviously there's more dissection and there's more exposure. But with the presence of the regional blocks, we've been in the multimodal pain regimen, which means that we'll give your child some IV Tylenol and some IV anti-inflammatory agents around the clock for the first couple of days. And we've been able to reduce the amount of opioids that the children need with very low pain scores when we place a block in the operating room. And one thing that we do to help with the pain as well is to try to get the chest tubes that collect the fluid around out as soon as possible to minimize the discomfort.
Thank you, everyone. An additional question, perhaps Dr. Ma can answer this. They said, are ASDs and PFOs the same? My chart has stated that I have a small ASD slash PFO.
Thanks, Hope, for that question. So PFOs are usually what we call when children are first born. All fetuses need to have a PFO in order to adequately supply blood flow when they're a fetus. And the difference is a PFO often has a little flap on the left atrial side. And so when the left atrial pressure increases after the baby takes their first breath, it is able to close off and so seal off the hole. In 20% of individuals, that hole stays open throughout their lifetime. And it often doesn't need to have any intervention done, although in the adult world, if they have any risk of stroke or any blood clotting issues, then sometimes the PFOs are closed in the adult world. In the reason sometimes in echo reports it says ASD or PFO is that you can't actually often see that flap, or the imaging isn't clear enough to differentiate the two. But they mention that because often, even in a small ASD, you don't need to have any intervention done because it doesn't tend to cause the right side to dilate.
Thanks, Dr. Ma. Let's see. Another question I see here is, how soon can my child go back to sports after a thoracotomy versus a sternotomy for this procedure? Dr. Baird, perhaps?
Yeah, I'll chime in a little bit here, and then the cardiologist may want to add a little bit. So with this, a sternotomy, a little bit depends on how long or how big the sternotomy is. So if you go from the front, your sternum is split, then that bone needs time to heal. And to do full contact sports, that's a good amount of time. And one may argue you need a good 4 to 6 months to let that heal before doing full contact sports. If you do a partial sternotomy where the full sternum is not healed, you can probably shorten that to maybe 3 months. And again, arguably not full contact sports at that time. If you do a thoracotomy and you don't have to split ribs and you're only spreading the ribs and you've never had to split the sternum, I would advocate that whenever the pain is controlled and resolved and there's no more pain, which is in the order of weeks to a month, then you can resume full activity. So I think it varies and depends a little bit on the patient and the scenario. But for resuming full daily activities and most all activities most kids want to do, then you can pretty much resume those pretty soon thereafter.
I was just going to add that when Dr. Baird says, pain medication after surgery, all children are able to be discharged just on just Tylenol and sometimes ibuprofen. And those are usually continued for a few weeks after surgery. But by 3 or 4 weeks, it's rare that there's any need for medication at all. And children can recover and continue to do their daily activities, certainly go back to school in 2 or 3 weeks after this type of procedure.
Thank you. Another question from the chat. Typically, how long is a surgery? I assume they're asking how long does it take to complete this thoracotomy ASD?
Yeah, I think you have to look at the total time of surgery. I look at it in several pieces. The anesthesia requires some prep time, and in general numbers, that takes an hour or so. And then surgery requires some time. And for a thoracotomy ASD, it's around 90 minutes to 2 hours-ish. And then the anesthesia to get the patient presumably extubated or to the ICU is another hour. So it's give or take around 3 or 4 hours for the process for a relatively straightforward ASD from a thoracotomy approach. The other thing you have to provide time for is the block, the paravertebral block. I've included that in the anesthesia time, but I think there's a lot of processes that go into that. But if you're asking specifically about the operative time, it's less than 90 minutes probably.
Thank you. And as a follow-up, how long then does the catheterization procedure take in comparison?
I would say it's not that dissimilar from what Dr. Baird described. Dr. Atkinson had mentioned there's still the going to sleep, everything's made sterile. There's the transesophageal echocardiogram that we have to do. And then kind of start to finish, we're probably looking at 30 to 60 minutes, depending on the atrial septal defect size and whether it's difficult to get a device to sit properly.
Wonderful. Thank you, everyone. I think that is the end of the questions that we had submitted. And so I'll go ahead and start wrapping this up unless anyone has anything they'd like to say. Okay, so thank you to all the panelists for your time today and for sharing your expertise. And thank you to the families who tuned in and sent the questions. As we close today's webinar, hopefully you've gained a clearer understanding of the benefits of a minimally invasive ASD repair approach that we offer here at Boston Children's. Hopefully you are feeling a little more confident in the options that you have for your child. And our team is proud to offer this option for families to keep, combine our expertise with deep commitment to personalized and compassionate care. As a reminder, this recording is going to be added to the BCH YouTube page, so you can come back and watch again in case you missed some of the details. And thank you again for joining us.